So welcome everybody. My name's Matt Fagg. I'm Director of Prevention at NHS England. I'm very grateful to Ash for inviting me to chair this important webinar, which is about uniting places for a smoke-free future. We're here specifically to mark the launch of an impressive suite of resources which Ash have developed to facilitate collaborative action by ICSs in reducing smoking rates. I'm very impressed with the work that Ash have done, and I have to say that for an organisation with an establishment of less than 10 whole-time equivalents, I think they really punch above their weight. So a few brief introductory remarks by way of setting the scene. So in 2021, 13% of people in England smoked. We've had a declining trend over a number of decades, but still over 500,000 admissions attributable to smoking annually. And that's against a backdrop of reducing public health grant allocations. Stop smoking services and tobacco control funding was 41% lower between 2022-23 than in 15-16, and as a consequence 75% fewer people set a quit date via local authority stop smoking services in 21-22 compared to 12-13. So the important point is that smoking hasn't gone away, and it remains the single largest contributor to health inequalities, with prevalence far higher in certain groups, particularly amongst the core 20+ populations. For example, 1 in 4 people employed in manual and routine occupations still smoke, which is almost double the rate across the population as a whole. And it was for that reason that we explicitly incorporated smoking as a priority in the core 20+5 framework. That's really important because it has facilitated the use of the health inequalities adjustment to address smoking, and a number of ICBs have taken advantage of that, and we will hear from a couple of those in a minute. We're also funding the establishment by the NHS of in-hospital tobacco dependent services. So that signals a much more active role for the NHS in tackling smoking than we have seen in the past. Tackling smoking aligns closely with the purpose of ICBs. So ICBs have 4 core purposes, if you like. The first of those is to improve outcomes in population health and healthcare. We know that smoking is the leading cause of preventable death and disease. So stopping smoking will support reduced premature mortality and reduced morbidity. The second purpose of ICBs is to tackle inequalities in outcomes, experience and access. And we know that smoking contributes half of the difference in healthy life expectancy between the rich and the poor. So it's really important we tackle it if we want to tackle health inequalities. The third purpose of ICBs is to enhance productivity and value for money. We know that smokers have poorer treatment outcomes from surgery, from cancer and from CVD. So if we stop more people smoking, that will improve the efficiency of services. And finally, ICBs have a purpose to support broader social and economic development. And we know that smoking impoverishes people. It costs smokers around £2,500 a year and reduces their ability to work due to poor health. So therefore, very good reasons why tackling smoking should be a priority for ICBs. But the NHS needs to work with local government in particular. Local authorities continue to make a really important contribution to protecting health. They continue to be the main commissioner of stop smoking services, but they also have broader regulatory functions that are really important, particularly taking action on illicit tobacco. So to maximise impact, we need to align the efforts of partners across the system. And we're going to hear today about some of the places that have been doing that. And we've got an impressive lineup on the agenda. If I could have the next slide, please. So we're going to hear from Ailsa Rutter, who's the Director of Fresh and Balance in the North East. They've got a well-established regional tobacco control network up there and a successful one. We'll hear from Debbie Watson, who's the Director of Population Health at Tameside Metropolitan Borough Council on their Make Smoking History project in Greater Manchester. We're going to hear about work to establish the Humber and North Yorkshire Centre of Excellence in Tobacco Control. We'll hear from Scott Crosby, who's the incoming Associate Director of the Centre, and Peter Roderick, who's a consultant in public health at the City of York Council. And then finally, from Dr. Emily Reid, who's going to present on the ASH toolkit. She's a public health registrar at ASH. We'll then have some time for question and answer if all of the speakers keep to time. Very brief points of housekeeping. So the meeting's being recorded. We will circulate slides and we'll upload the recording to the ASH webinar page after the event. We would ask all panelists and attendees please to stay muted and turn their videos off unless they're presenting. We would also encourage all attendees please to submit questions and reflections in the meeting chat, and we will try and pick those up at the end. So without further ado, if I could invite Ailsa Rutter, please, to take the mic.
Thank you very much, Matt, and I'm delighted to be here today, and a huge thanks to everybody for making the partnership approach up in the Northeast, you know, a success, and 18 years later that, you know, we're still going, and this is very much, you know, a huge big partnership of many. I've been asked this afternoon to focus specifically around the advocacy role that a super local programme can play and how advocacy can support a comprehensive strategy. And in the Northeast we do have an ultimate goal really to end smoking as such. If I can move to the next slide, and then what I'm going to quickly do in 10 minutes is the why. So why do we have this regional programme, who we are, how we've been set up, what our key focus is in the 8 key strand approach, but specifically the advocacy role, and finding out more at the end. And Catherine from the team is also on the call today, so can also help with questions. Next slide, please. So many of you will be familiar with this. This just looks at the progress to address smoking since the 1950s. So it's Cancer Research UK, who are a really important partner to both us and ASH and many. And I think it's just really sobering for us to reflect this. And 75th anniversary of NHS last Wednesday, and reflection for us was in 1948, 82% of men were smoking. So gosh, how far we've come. And if you look at tracking this, it looks at men's smoking rates and women's smoking rates. And then also last week, we also saw the publication of Cancer Research UK data that shows that in the next year, sadly, lung cancer rates in women will overtake those of men. And that, you know, very much tracks you know, the differing times that smoking uptake happened between men and women. What I wanted to just flag with this, though, is looking at the great progress that has been made. But we all know, all of us here today, that why we're still focused on smoking, it is the key reason to tackle health inequalities. And particularly in the last 20 years, advocacy has been crucial, because through advocating on the evidence base and using the science and the data and the research is how we've made the case for a succession of tobacco legislation and regulation, which has been incredibly important to help drive down smoking rates. So thank you to everybody who made that possible. Next slide, please. So the FRESH programme is a comprehensive programme. It's got 8 key strands of work. They all designed to work together synergistically. There isn't one magic solution. And really importantly for tobacco control, there needs to be a focus from international down to local level. The FRESH programme is a super local programme, so it's around population level working. So this is opposed to simply targeting individuals, but it's about shifting the societal norms. It's been around, you know, making tobacco use and the industry less attractive, less affordable, less accessible. And partnership and collaboration is being key. So from the very beginning in 2005, when we launched, we said that smoking was everyone's business, that there is a programme, a small team, but it is very much around the really important role that NHS, local authorities, voluntary sector, business, lots of others can play to unite behind that very clear vision. The programme also helps coordinate the Smoke-Free NHS Task Force and programme, and many of those colleagues are here today, and we absolutely are delighted at the fact that we've got such a key focus from our ICS on both long-term plan, but also our ICS recognising the impact around tobacco control. So it's a one big team approach. Next slide, please. We have a strategic plan, so we are commissioned for the next 2 years by all 12 North East local authorities and also our ICS Integrated Care Board. So it's an equal funding, and both the local authorities and the ICB are contributing 27 pence per head to the programme, which gives us a combined budget of 54 pence, which is around 1.53 million, which, you know, is certainly exceptionally welcome to us. And I suppose what this reinforces is it's not huge millions of pounds worth of money, but when spent cost effectively and, you know, on an evidence-based footprint, you can get an exceptional bang for your buck. Durham County Council is our lead commissioner, and Amanda Healy is the Director of Public Health there, and they commission the Fresh Balance programme on behalf of the other local authorities. We are hosted by an NHS Foundation Trust. We have been since 2012, and we're population level, and it's about partnership approach. Next slide, please. Oh yes, local tobacco law licenses are exceptionally important. If we think now about our key strand around advocacy, so this is very much around working closely with ASH, and it's about being an active member, core member of the Smoke-Free Action Partnership. And it is about setting very clear objectives. When Fresh launched back in 2005, we weren't at the time talking about ending smoking. We now have a very clear goal to reduce smoking to 5% or less across all groups by 2030. We're not on track for that nationally, regionally, locally. We know that there is much more to be done on that, but there's a very clear sense of vision now in the North East in terms of ultimately smoking had a beginning, it had a middle, and we wanted to have an end. The clear ask at the moment is that we need a properly funded new tobacco control plan. Our key policy asks include around a statutory levy, and they also include around raising the age of sale to 21. We work very collaboratively, the leadership of ASH, so this is about responding to consultations, it's about our support to localities when there are things like the major condition strategy, and how vital it is that we harness local voices around this as well. In terms of framing the debate in the North East, we talk much more now around economic recovery, we talk much more around the impact of smoking on business, and it's not just around health and social care. So building that evidence, the case for it, we use the ASH Ready Reckoner lots and lots of our PR. We've done lots to develop political champions, so the role of the APPG on smoking or health, and the fact that we've got various prominent North East politicians who support that important group. And working with ASH, we've been able to track public opinion over many years now through the annual YouGov survey, and really importantly, the power of real people. Their voices are crucial, as you'll see in the next couple of slides. And then finding the right lever. Next slide, please. And just in terms of that high level of public support, you know, in the North East for our regional programme, we're able to have annual data that shows that there is high levels of North East adult support, and it's only 6% of the North East adults that think the government's gone too far. And on the many key asks that we have now, we also see very high levels of support, which is just very reassuring to be able to provide to elected members. Next slide, please. So we have leadership from many. So yes, Fresh is at the helm, and Fresh is the team that coordinates a lot of this, but the vital role of distributive leadership, and a huge thanks to our directors of public health in the North East. They're very strong on tobacco, and this is an example of this in a public letter that was published for the 15th anniversary of smoke-free law last year, where our DPH has said we need a new tobacco control plan to end smoking. Next slide, please. And including other messengers, this little thing here is just showing some of the people. So at the bottom right is the chair of our ICS, Sam Allen, united with the chief exec of the North East Chamber of Commerce. When the ASH Ready Reckoner results came out a few weeks ago, this was them backing our press release. We also have the leadership from Ruth Sharrock, who is our ICS clinical lead for tobacco dependency. We have our ex-smokers, cancer survivors, who are able to advocate on our behalf as well. And this is just in the middle here, is just hot off the press last week, was when those lung cancer figures came out. Kathy Hunt, who features in our Smoking Survivors campaign, said, "We should be furious tobacco companies targeted women. There's nothing glamorous and worrying. You won't be around for your family or the scars from surgery." And we're able to do this within half an hour, really, of that news hitting the media. So being very responsive. Next slide, please. So this is all part of our year-round communications. So it is also about, as a super local programme, we're able to do year-round PR and media. We have a very proactive press office. We live and breathe this. We're available 24/7, 365 days of the year. And that's so important if we're going to, end smoking. Ultimately, it's about shifting the social norms, so harnessing public support using our local case studies. And we have, you'll hear about the fantastic work in Greater Manchester on their media campaigns, and that's very much part of what we do as well. Next slide, please. And these are just to flag to you. So our smoking survivors, your local people, your local case studies can become your biggest advocates. So this is Sue Mountain. This is Kathy Hunt. These are examples of 2 TV ads that are on air at the moment. And Sue and Kathy, I'm delighted, will be at the APPG on smoking event next week. And what they say is so much more important than what I've ever got to say. Thank you to them. Next slide, please. And the advocacy lessons learned really is always using the evidence base, keep up to speed, be tenacious. Things don't happen quickly. There's loads more that needs to be done. You know, it is really important that you have a clear sense of your vision, keep being bold, be ambitious, know who can speak out on your behalf. Absolutely, there's political will, you know, real people over stat, a compelling narrative, and remembering ultimately for Fresh here in the North East and for all of us up here, this is about our loved ones. And I always use the next slide, thank you, because it makes it really, really real. Nearly 8 million lives have died from tobacco in the UK since 1971. You know, 26% of all deaths. That's my dad, top left. That's Alice Wiseman, DPH for Gateshead dad underneath him. So this is why we're doing this, because these were all avoidable deaths. And the next slide is just our finding out more information details, but new website, freshbalance.co.uk. Thank you enormously.
Thank you, Elsa. Really helpful and really powerful at the end, pictures of relatives. Now, if I can invite Debbie Watson, please, Director of Public Health at Tameside.
Thank you, Matt. Good afternoon, everyone. Hope you can see me there. Can I just check that you can hear me? I've got a feeling my camera's not working. I can see you.
No, but we can hear you okay, so I suggest
okay, I'll just make a start. Don't worry, you're not missing anything by by not seeing my camera, and hopefully this won't make any difference to updating you all around our Making Smoking History in Greater Manchester strategy. So if I could go straight on to the next slide, please. Oh, I think I might have appeared. Okay, so good afternoon, everyone. Thank you so much to Ash for inviting me to present this afternoon. A real honour to be amongst such advocates of making sure that we can make smoking history across the country. So I'm just going to give a bit of an update and an insight on some of the work that we've been doing in Greater Manchester. I'm also joined by our consultant lead, Andrea Crossfield, who's been instrumental really in driving forward the work in Greater Manchester, and I know is available for questions as well. But just to say that our Making Smoking History journey really started with some pace in 2017 when we first published our strategy, and since 2018 we've been really investing at pace and scale, collaboratively and together, in an evidence-based multi-component approach within our strategy based on the World Health Organization Empower model, with an additional social movement focus that's really been led and driven by our localities and our voluntary sector. So in terms of impact, we've reduced smoking prevalence. We've got 66,000 fewer smokers, and we've begun to work on tackling some of our real stark smoking related inequalities, reducing rates of smoking in pregnancy, in our LGBT communities, in those with mental health conditions, and ahead of the pandemic we were having a real impact on routine and manual smoking populations. And while we've made some really great progress, as outlined here, and we've been recognised for the work we've done in Greater Manchester, smoking does remain our largest preventable cause of inequalities. Next slide, please. So, you know, the recognition that we've received in particular from our Stop Smoking in Pregnancy and our cure programmes is really testament to the levels of innovation and scale of system transformation that's taken place since 2018 to deliver those results. In terms of our latest data, our smoking at time delivery has reduced by a quarter. We've got 1 in 4 patients in our hospitals arriving as a smoker. So in terms of that NHS reform, that cure intervention, which is our secondary smoking addiction service, we've got real kind of engagement across Greater Manchester in terms of that. 1 in 4 of those smokers quitting at 12 weeks post-discharge, really positive impact from that. We've now got our cure programme in place across every Greater Manchester acute hospital, and a specialist mental health cure service has just begun in April 2023. So when cure is fully operational, we can expect 36,000 12-week quits from that cohort of smokers, reducing admissions and saving lives. So a real drive for us in terms of our GM programme. But we do recognise that programmes like this take absolutely time to embed themselves and to be fully delivered. We're 5 years in at the moment, and the Ottawa programme, which the cure programme was based on, was a 15-year endeavour. So we absolutely reflect that we need to review our progress and keep our eye on impact. Next slide, please. So one of the opportunities we have to harness the power of kind of change is looking at the way that we deliver our services and the way that we're transforming our service delivery, including using the power of digital innovation and digitisation of some of our offers. So in GM, there's a real kind of opportunity in terms of the work that we've done together to work away from siloed approaches to much more partnership working with our residents and communities, using the work that we're doing on data architecture and capability to deliver much more innovative interventions and more integrated offers that's person-centred, and the rest of this presentation really is going to focus on that, around insights and around some of the ways that we've been creating a culture where making smoking history is the norm. So we know that quitting is a journey that people are on, and on average it takes a lot of quits attempts to actually quit in the end. But we've got a real opportunity, I think, to develop a much fuller, holistic picture of people's lives and barriers to quitting, and that's something that we feel is really important to support their quit journeys, so that actually within our localities we're alongside our communities, continuing to offer that right support at the right place, because we know that that's going to give them the best chance of success of quitting, and welcome them back into support if life gets so tough that they need more support and they relapse back into smoking. So that's just some of the ways that we're reimagining our quitting journey. Next slide, please. Okay, just quickly, since the programme started, this is just to show our trajectory and where we're going. So our smoking prevalence in Greater Manchester was at a record low. It fell by 3 percentage points from 18.4% in 2016 down to 15.4% in 21, a greater reduction than England there. In terms of GM's ambition for a smoke-free region, we are aiming towards the government smoke-free 2030 targets there. And in terms of the speed in which smoking prevalence is declining, you can see there that we've started to stall, and we've had the negative impacts, I think, of the COVID pandemic, where GM was an area of enduring transmission, and we were very badly hit by the pandemic. What we're looking at now is our new Making Smoking History framework as a real opportunity to upscale our efforts to bring us back on track, and with the other challenges that our residents have got in terms of the cost of living crisis and increasing mental health issues in our population, we absolutely can't underestimate the scale of the challenge. Next slide, please. So in terms of building on our successes and learning, we're going into a new phase really, and we're looking at a new Making Smoking History framework. But we recognise that we'll only make this work for our communities if we mobilise all our 10 local authorities, all our communities, and all the work that happens in those communities. So we're at a place of strength. We're already got good working relationships and collaboration with the voluntary sector. We've got framework actions that are delivered at both a Greater Manchester level, a sub-regional level, but also at that locality level, and activity right down into neighbourhoods and communities. And we are trying to build in assurance and governance and ownership and leadership within our health and wellbeing boards, our locality boards, right down into our neighbourhood teams. I think in terms of insight, I think what we've realised is the culture is our biggest lever for change, and engaging local people who support our ambition and want to see GM at the forefront of making smoking history is absolutely critical to the impact that we're making locally. So the vision for culture change has been co-created in partnership with our communities and key stakeholders through one of our programs called History Makers. So we've done a lot of engagement and are investing in a new engagement and communication strategy to deliver that change for populations. Engagement and behaviour change interventions are absolutely critical for attempts for quick success, for preventing that relapse, and also reinforcing quitting, with support as being the social norm. So today, the investment in our behaviour change campaigns has seen people making more quit attempts in GM than the England average, and the work that we've been built on has had intensive insight, as just outlined in my next slide, please. So this kind of gives you a timeline of the monitoring and insight that we've been doing over the last few years. So all our engagement and behaviour change has actually been based on population insight, engagement and co-production. And you can see that in the journey that began a whole population consultation, engaging 8,000 residents across Greater Manchester to provide a representative sample in each borough. But what it did show us is that not only did 8 out of 10 people want to make smoking history, but over half of all our smokers also agreed. And I think that gave us a lot of leverage in terms of access and support in terms of the measures within our strategy. And we followed that up with a lot of quantitative and qualitative segmentation of our population. And did some deep dives into some of those inequalities, underrepresented groups in our stop smoking services, such as LGBTQ plus smokers. And since 2018, I think Greater Manchester has developed regional campaigns that have been based on that insight around people's voices, as Ailsa has just mentioned, looking at the human cost and thinking about personal stories. And on average, when we've done evaluation, our campaigns have been reaching 8 out of 10 smokers and inspiring 3 out of 4 of those smokers to take some positive steps towards quitting, either by seeking support, cutting down or stopping smoking entirely. The campaigns have helped raise awareness around our stop smoking support and our tools, and warned about the dangers of smoking tobacco, key to discouraging obviously our young people from ever starting to smoke too. And our insight has also helped us shape other programmes within the Making Smoking History programme, including our smoke-free spaces programme and places. But I think what we really need to do is understand the context of people's lives. So we've recently done a social housing survey, and over 1/3 of our smokers were accessing food banks compared to 25% who didn't smoke. And we need to be integrating a lot of this work into our work around tackling poverty and into our housing work at System in Place. A real learning and insight moment for us there. So next slide, please. So in terms of what we did, so the insight from the pandemic helped us develop our current campaign, which is Never Quit Quitting in Greater Manchester from 2020. Are you going to tell me I've got about 2 minutes left, Matt? Okay, so lots of information about that quit can be found on our Making Smoking History website. So if you can just skip forward to my last slide, please. So just don't want to read this through, but didn't want to finish without talking about the real impact. Similar to Ailsa's point there, you know, GM has got a strong history of local social movements and activism, and it's really key to shift those social norms. But to succeed and continue to support, really believe that, like Lisa, we need to continue to invest in that whole system approach, listen to our residents, build insight, celebrate our successes, but also recognise the importance of people and place. Thank you. Sorry, Matt, I went over a bit there and missed a slide, but I believe the slides are going to be sent around as well, but thank you.
They will be circulated. Thank you very much, and thank you for all the leadership that GM have shown around the Cure approach. It's great stuff. So we're going over the Pennines again now to God's own country. So Roderick and Peter and Scott, I invite you to take the mic.
Thanks very much. I'll kick us off. Good afternoon, everyone. I'm Peter Roderick. I'm a consultant in public health, but also a Deputy Director of Population Health at Humber and North Yorkshire ICB. If we can flick to the next slide. I think what people have heard this afternoon has been a brilliant demonstration of, I guess, something that's been decades in the making, something that's been years in the making. And I think now we're getting onto the stage of months in the making. And I hope that's helpful, actually, because I think what you've seen this afternoon is something about the long-term impact of working regionally and effective regional campaigns, which is hopefully given people that real motivation that actually at the end of this is some population level impact, some lives changed, some real public health done. But what we're about to present to you, me and my colleague Scott, are really how you get from a standing start to we've got a thing, and that's pretty much all we've done so far is to have a thing, but it's actually been from a place where Humber and North Yorkshire probably wasn't leading the world in tobacco control, I think it's fair to say, and as an ICB has been one of the newer sort of SDP ICS areas, but has over the last 6 to 12 months has drawn together a lot of work and really focused on the area of tobacco control, and has started to make those baby steps into the types of programs that we've seen displayed in Greater Manchester and the North East, which I hope is positive, giving you that sense that it can be done in a variety of different ways. We've secured funding from the Health Inequalities budget of the ICB to go beyond our delivery of the long-term plan. I think I'd emphasise that it was based on the fact that our long-term plan work was being delivered, and we were putting the resource in there to make it effective, and demonstrating that the collaboration was strong around delivering the long-term plan in secondary settings. I think gave a little bit of the credibility to say let's go beyond into, I guess, what you might call comprehensive tobacco control. So we've allocated a proportion of our funds. It's about 45 pence per head for Humber and North Yorkshire. £863,000 per year from next year. Sounds a lot of money, and sometimes I feel saying that amount of money in some settings feels as if, gosh, that's a big investment. I think it's helpful to draw comparisons. That's about the same amount that we spend on vasectomies in our local area. So actually, big sums of money can sometimes not necessarily be as big as we might think they are. And actually, if we're talking about the single biggest, most preventable killer in our population, that's a very small amount to be spending on something so crucial and as important as ending deaths and ending early disease from smoking. It's going to enable us, as I say, to move beyond merely to treating tobacco dependency, which is a crucial part of what we're doing, into wider tobacco control measures around advocacy, around policy, around communications and mass media. And we couldn't have done what we've done so far in 6 to 12 months without the support of ASH, who have been absolutely vital in helping us just understand, as an ICB, which doesn't have a history in this area really, where is our existing activity within our local authorities, what are local authorities' priorities, what are our tobacco control successes in the areas we might have wanted to do more on if we'd had the opportunity, and therefore together what should our priorities be for the next 2 or 3 years as we start to set a comprehensive tobacco control approach up. The working title for it is the Centre for Excellence in Tobacco Control for Humber and North Yorkshire ICB. So that's what we've been working with as a title so far. Next slide if we can. So our proposal is 3 areas. Thanks, brilliant to bring them up all at once. That's very helpful. So really I think this has been part of our tactics within the ICB, is to talk about coordination across our areas and to talk about the things that we can do at scale most effectively. So mass media would be a good example of areas local authorities have come to us and said, do you know what, it's been very hard to devote local authority budgets to doing the type of cut-through campaigns we know are needed on tobacco control. How can pooling resource across a population of 1.7 million actually lead to better bang for your buck than you might get on 6 local authority different areas? Similarly with illicit tobacco leadership, where we see in our particular geography 2 or 3 actually port areas in one bit of our ICB's geography being an entry point for a lot of the illicit market, but then spreading out across the rest of the ICB. Illicit tobacco doesn't really respect local authority borders, so how do we coordinate, how do we collaborate across them? And thinking about other areas where we might coordinate across the ICB, such as our work on children vaping and vaping policies. So we've got that coordination piece. We've also got some things that we want to invest in services that are at system level in an ICB. So for instance, as we roll out lung health checks, typically that is a program that's connected with local cancer centres and secondary trusts. It doesn't make much sense to fund smoking cessation embedded in lung health checks on a single local authority footprint. So we've been doing it across the whole of the ICB. Similarly, when it comes to engaging with clinical education routes, sort of nursing, doctors, postgraduate medical education, actually again one medical school for our area, how we engage with them as a system. But then crucially, that third box about place-based investment, we're an ICB built on 6 places. We are a system, we're not simply the NHS, we are all of the third sector organisations in each of those places, all of our local authorities. So how do we make sure that there's a sense in which this ICB funding can flow out to place well? How do we make sure that each of our local authority community stop smoking services have the gold standard level of tobacco dependency treatment and smoking cessation advice? How do we make sure that our VBA a training for professionals working in housing, for instance, working in culture and leisure, working in various different sectors is really gold standard? And how do we make sure that when local authorities such as Kingston upon Hull, which has the highest smoking rate of any local authority in their country, when Hull starts to think about its inequalities populations, a ward like St Andrews and Docklands with 41% smoking, so one of the highest ward smoking rates in the country, how do we help them reflect and use some of our system resource to tackle those type of deeply entrenched inequalities? Next slide, if we can. So this talks a little bit about what our coordination work looks like across the ICB, and I'll just use this slide to gently draw out one of the key areas that I think it could be seen as a challenge if it's not tackled right, which is this thing about advocating for effective national policy. And I think within local authorities that sometimes presents difficulties, doesn't it? Because we have different political colours in charge of each of our local authorities and different approaches to advocacy and calling upon the government for health policy change. I think doing it at an ICB level has enabled us to identify some areas in which we can collaborate on when it comes to advocacy. I also think that from an ICB perspective, it's probably one of the safest areas to be advocating on. If you think about things that Elsa listed earlier on, such as the change of age of sale upwards, the case for tobacco and the case for the health implications is just so strong that actually normally cautious approaches to advocacy within an NHS sort of body space like an ICB, actually we have felt we've been able to get people into that space to be able to talk on an advocacy perspective. So this slide just talks a bit about our coordinated action. The next slide talks a little bit, I guess, about the values that have been around this. We're trying to build something that is additional to what was happening across our 6 local authorities and their stop smoking services. It doesn't replace them, and actually the people who are in charge of those from a commissioning or provider perspective are actually involved in the design and creating with us. We probably haven't got that right 100% of the time, but actually been really keen to get everyone bought in and delivering that with us. We're aligning and we're not duplicating. We're system, we're not just NHS. This is funded by the ICB, But I think ICB has been really clear that this is actually the integrated care system, including local authorities and third sector. So it's not an NHS takeover of work on tobacco. We want to be nimble and innovative. I think we're very much learning on our colleagues who have just preceded me in this webinar, something about the innovation, something about the responsiveness, particularly to news stories that come out from different national organisations about the effect of smoking and how we are quick off the mark on those, and generous and parochial. So not parochial rather. So we've got an ICB that is 1/3 of Yorkshire and the Humber, but we know our West Yorkshire and South Yorkshire colleagues are very much looking at some of the work that they could do in this area. How do we share the learning? How do we make sure that we're not just talking about our ICB, but thinking maybe slightly pan ICB within our local government office region? I'm going to hand over to my colleague Scott. He's going to talk a little bit more, and Scott can introduce himself and his new role within this whole piece.
Thanks, Peter. I'll be as quick as I can. So I'm coming in to the programme as the Associate Director to lead the programme. I just wanted to cover two questions really that's really sort of come up since I've been tied to this role. So there were two questions here. Kind of what will it look like? And with a few assumptions that we'll kind of be lumping everything together into one, which is not the case, and that you know, Yorkshire is very, very different, and they couldn't do it here. Well, I agree with the first one that we're very, very different, but I believe that you can do it here, and I'll come on to that now. So if you can go on to the next slide, please. So here it is, really. I think this is the magic phrase which Peter's come out with. It has to add value to what's happening there. So we're putting in additional investments, but it also has to have that added value. And we have to be very clear on the roles and responsibilities here. So it's all about collective impact. So that question there about pooling and being one a tobacco alliance is just really not the case, because what happens is that at place is really, really important. So we will be making sure that local authorities and the investment that they put in are supported, because they are the ones that will be targeting the areas and the neighbourhoods that they know the best in that place. Then we've got the system level, but what we're looking for across the centre is that added value in terms of economies of scale and the population level measures that Ilse talked about, so we cross all three. Next slide, please. So in terms of kind of Yorkshire's different, you've got here, we've got in Yorkshire, we've got 3 ICSs, and this is just one of them, Humber and North Yorkshire. And on the right hand side, you've got a coastal that looks over into the North Sea, and you've got the Humber estuary, and we've got one of the biggest geographical areas of ICB. It's really huge, and it's really, really different, as Peter alluded to. It's a new ICB. There's large variations, and being quite sort of completely honest, it doesn't really have that natural fit of working together as of other ICBs that we have. So I think what I'm saying here is that we've got some of the, in Hull we've got one of the highest smoking populations, and we've also got some of the lowest smoking prevalence as well. We've also got a mix of political makeup. So we've got 4 Conservative councils, we've got a Lib Dem council, and we've got a Labour council, and we've got big cities, we've got really urban areas, and we've got coastal communities. It's a really sort of difficult area to look at, really. Okay, on to the next slide, please. So that sort of brings us to the end of our presentation, but my sort of key, well, my key to you really is that if we can do it, then I promise you can do it.
Really helpful. Thank you very much indeed, and great to see. I remember attending your launch event not long ago, so it's great to see the programme of work starting to emerge. And thank you also for finishing broadly on time. So Emily, Dr. Emily Reid next.
Hi. Next slide, please. So thank you, Matt. I'm going to start with a bit of background. So Last year, Ash released a report on supralocal tobacco control, and that reviewed what tobacco control activity was nationally felt to be best delivered at scale. Then for about 6 months through to March this year, we were funded by NHSE and jointly commissioned by the Regional Directors of Public Health, with additional support from a Public Health Registrar and me, to support Humber and North Yorkshire ICB in the discovery and development phase of their Centre of Excellence in Tobacco Control. And from this, we've used that learning to establish a toolkit, which we hope will assist other areas looking to collaborate on tobacco control. And that's what I'm here to talk to you about today. Next slide, please. The toolkit was developed to support ICSs or regions that are aiming to go further and faster in driving down smoking in their areas. It's intended to help make the case for system-wide tobacco control and gain necessary funding, map existing delivery, develop a strategy based on the evidence of what works at scale, and calculate and allocate a budget. Next slide, please. And just a little note about what we're talking about here, which is hopefully very clear from all these brilliant presentations that we've had today, but we're talking about a collaborative model of tobacco control that involves NHS, local authorities and others. And we're talking about a multi-stranded tobacco control approach, not just about the delivery of stop smoking services. Next slide, please. So there's 9 documents in the toolkit and I'll run through each of those in turn. Next slide. Thank you. Okay, so the Creating Conditions for Success poster will be the first place to look for someone who's looking to consider a system-wide programme. It helps the user to understand the process and what might be needed to get a system-wide programme off the ground. It includes stakeholders you want to consider, stages of development and building blocks for success. And at this early stage, you might want to be considering what kind of geography you want to work across. So you might want to consider media boundaries, trading standards grouping, ADPH networks, HMRC and policing boundaries, and the roles of combined authorities, as well as ICSs and things like that. So you'll also need to consider who the key people are that you'll need to get on board at an early stage. So these are likely to be your directors of public health and your ICS and ICB leaders. But you also need to think about finding someone that's dedicated and suitably senior enough to drive the progress of this, apply for funding and bring your stakeholders on board. Next slide, please. So directors of public health will be key leaders of any system-wide programme, and you want them to be acting as champions and leaders to bring together different agencies to take a partnership approach to tobacco control. Because of this, it's really important to bring them on side at an early stage, and the DPH briefing paper can help make the case to them and bring them into the planning process. It's a generic document and you can adapt it as you need to. Next slide, please. The regional programme should have a distinct programme of work, as we've heard today. So when you're planning a programme, it's really important to understand existing tobacco control activity across the places within your region or your ICS. And the local authority mapping template can be used to facilitate discussions with local authority tobacco control leads and trading standards officers to be able to achieve this. You could also consider doing a clear assessment, and separately, we would also suggest mapping the progress on the long-term plan through the long-term plan dashboard, or through discussion with those coordinating on the long-term plan through ICBs and trusts. Next slide, please. You also need to identify a funding source and secure the funding for your programme. So our suggested funding source is the ICB Health Inequalities Money, which uses the Core 20+5 approach, but joint funding with local authorities or pooled local authority funding could also be considered. Once a funding source has been identified, the budget calculation template can assist in calculating the level of funding that might be required and broadly how it could be prioritised. So the calculator allows you to input your population and will give you funding options at 45, 60 and 80 pence per head of population. It will then auto-populate a budget guide for each of these funding levels, which suggests staffing and targeting of the funding. The calculator allocates funding towards staff first, and then it prioritises communications campaigns. This is because the mass media needs sufficient funding to reach its audience, and below a certain threshold, it will probably be a bit less effective. So despite being high cost, it has a wide reach, and therefore it will be cost effective when you're considering cost per quit. Another thing to consider is that you might want to be ramping up your funding over 2 years, like Humber and North Yorkshire have done. Next slide, please. If health inequalities funding is your chosen funding source, then the paper to the ICB board can help you to apply for it. It outlines the case for tobacco control in terms of health inequalities and policy contexts, and suggests areas for action. It's a generic document, but it has directions for adapting to your local use. Next slide, please. To help bring wider stakeholders on side is the Making the Case slide set. So this is a presentation which again outlines a case for system-wide tobacco control in terms of health, inequalities and economics in the wider policy context. and it's designed to be completed using statistics for your own area. Next slide, please. In order to do that and to complete some parts of the ICB board paper, we've developed the supporting spreadsheet, which directs you to the source of the statistics used in the presentation and calculates figures for your regions or ICSs from smaller geographies, if the statistics for your regions or chosen geography isn't readily available. Next slide, please. A further key document to look at early on would be the Building the Strategy slide set. So this outlines the suggested options for action at a system-wide level in more detail and how we would suggest prioritising funding. And it also includes Humber and North Yorkshire's provisional strategy as an example. Next slide, please. So finally, Elsa has kindly shared a presentation with us outlining the strategy from fresh. So as our longest running and gold standard programme, we think this will be really helpful in guiding new programmes in the development of their strategies. And last slide, please. So yeah, thank you very much for listening, and thanks to all the brilliant regional programmes who's provided input and feedback into the development of these resources.
Thank you, Emily. That's really helpful, and there's a fantastic suite of tools there for anyone that's looking to replicate the sorts of approaches that we've heard about from North East Manchester or colleagues in Yorkshire and Humber. So very helpful. So there's been a bit of dialogue in the chat, and we had some questions which were submitted off the chat directly to Ash. So we've got a number of questions. So we're talking about regional networks. Is that the optimal footprint region rather than ICS? Any views on that at all?
Should I stick my hand up?
Yeah, please.
So I suppose a lot of what Emily's just outlined is some of the things that are best done at scale is things like media campaigns. So certainly in the North East, it's been quite helpful simplistically for us that our ICS footprint matches what was the old government office footprint, and there and also with our kind of mass media TV transmitter footprint as well. When you look at the fantastic Ash resource, it is about working out what are the things that you want to do across a bigger scale. So I don't want to say you have to do exactly our footprint, but certainly, you know, what you don't want to do is having too many things too small. It's about trying to work out what is sensible for you, you know, and your natural allegiances within that area, if that makes sense.
Yeah, it does. And kind of getting the economies of scale where it makes sense to have economies of scale. And there is a request from Nisha to please stop sharing the slides so that we can see the speakers better. So if you wouldn't mind putting the slides down at this point, that'd be great. And do you find that there are tensions between the kind of drive to do things at place-based, community-based level versus doing things at a kind of larger geographical level? And if so, how do you kind of get around that?
Do you want me to say for North East first, Matt, or?
Yeah, please.
No, not now. I think because we've been working with our wonderful local partners for so long now. I think there is a pretty good understanding about what's best done locally. So that granular targeting of your key priority groups in particular wards and making sure you've got your stop smoking service there versus then what needs to be done regionally. But collaborating is key and making sure that your localities feel very much part of this. It's not a case of we're here and you're there. There's always room for improvement. People come and go. But I think if you keep the smoker at the heart, nobody owns smokers. We need to be really clear. This is about stopping people dying and get away from territorial kind of things. Yeah,
makes sense. Thank you. And thank you for taking the slides down. The other benefit of that is I can see that people have got their hands up, which is helpful. So Debbie, you were first. Did you want to come in?
Yeah, thank you. Just wanted to kind of add to what Elsa said in terms of obviously I think the main message was that we're not going to be able to make the impact we want without doing that system-wide approach right down to neighbourhood level. And I think in Greater Manchester, again, we've got a strong track record of working collaboratively, and our GMA DPH group is actually a wider public health leadership network to include colleagues across the ICS, but also OHID, UCSA and the voluntary sector and our combined authority. And together, I think that what we really do recognise is the need to build in meaningful engagement with place and understand the needs of place, so that we can work with our locality teams as equal partners. Now that takes a little bit of effort and probably a little bit more time, but in the long term I think it really does pay off, alongside the engagement that we're doing with local people and the insight that we get from local people. You know, it really does work. But I think, you know, for myself as a DPH and a lead for tobacco at Greater Manchester, I'm aware of my role as being that kind of advocate for place, and make sure that we do build that in everything that we do. But it's quite a tricky thing to actually navigate the governance, both at a locality level and a sub-regional level and a northwest level, but we're having a good go at that, aren't we, Andrea? In terms of making sure that we are doing a meaningful delivery programme across the Making Smoking History programme. Thanks, Matt.
Thank you. And there's a number of comments in the chat. People kind of agree, and it's not a one-size-fits-all approach. I guess the difference between how you engage populations, so your messaging might be similar, but how you engage people in whole versus rural Cumbria might be quite different. Peter, did you want to come in?
Yeah, really endorsing what people have said so far. I mean, ICBs, there's a 3 or 4 fold variance in the side of ICBs. There are some local authorities which are bigger than some ICBs, so it will need to be that flexible approach. And I think what is brilliant, just to commend the work that Ash have done, particularly Emily has done on this set of resources, is it is flexible. It is nicely tailorable, that you can take some of the, I guess, the burning platform, the agenda for change arguments from it. You can take some of the calculation based resources and some of the persuasive arguments about why you would do work and fit it to your geographical a particular context. And what will make the difference will be leadership. And I think I'd observe, having spent a little bit of time listening to people from Greater Manchester over the last year, and from colleagues from Fresh in the northeast, is observing the sort of the levels of leadership and the sustained approach to this as almost a, I guess it's moral and ethical basis before we get to any of the practicals around it. I think those things get you through the tricky difficulties of, well, should this be done at that geography or that, or where should that rest? So I think, yeah, leadership is key, and flexibility in the approach that's taken.
Thank you, really helpful. There's a comment there about the leadership of directors of public health being really important. I mean, are there other kind of key people that you need to get buy-in from, or in your kind of local experience, who were the kind of key champions that you had to win over, where you got to that sort of turning point on this? Because I mean, my guess is a lot of the directors of public health will intuitively kind of agree with this anyway, but are there others that you need to win around?
We found in Humber and North Yorkshire, just to come and let others pop in, that it's very much helped having a chief executive of the whole ICB who came from the northeast and had seen the Fresh model. So that was probably one of the key bits that has really aided us. But I think obviously finance colleagues have to sign off for use of some of the health inequalities money and have to be assured that there's a return on investment. So again, back to Ash, again, back to Ready Reckoner, when we're talking to local authorities and not just DPH, we might be talking to directors of social services, even in a small place like York with its relatively low smoking population, £3 million in social care costs due to smoking. I think it's just being able to use that and having those things at your fingertips, which has really helped in those conversations.
Great, thank you. We've got 2 minutes left, so Ailsa quickly, and then we'll go to Scott.
Yeah, it was just to say absolutely use the Ready Reckoner, and increasingly in the northeast it's about economy. So it's, we've got really good links with the Northeast Chamber of Commerce, who traditionally were a really strong supporter as well. So just they've been really crucial for that, and elected members and leaders themselves coming out of the pandemic, they can absolutely see the benefits of reducing smoking. We want to have a healthy workplace, a healthy productivity. So it is about just lots of different bits of ammunition to use.
Thank you, Scott. last word?
I was just going to say that on where you need buy-in is everywhere. so it's not just one person. It's working on your directors of public health, making sure that your directors of public health understand the roles and why it adds value, but also obviously across the ICB colleagues. What I would say is that you will have colleagues that work in a kind of dual role, like Peter does across the ICB and in public health, and they will be kind of on the inside and on the outside, and you've got to be ready to kind of sell it in. When the opportunity arises, everybody's got to say the same thing, because there are so many competing priorities, as we know. So everybody saying the same thing around tobacco is going to be really crucial. But do the building, do the planning, and it will work.
Great note to finish on. Thank you very much. Well, look, we're out of time, so if I could just say thank you to everybody that's spoken, Debbie, Elsa, Peter, Scott and Emily, and thank you very much to ASH colleagues for arranging this. It's been, I've certainly found it really helpful, really useful to bring everything together. I hope other people have. Hope you enjoy the rest of your day. Thank you very much indeed. Bye now.